Bismillahirrahmanirrahim. Good morning, everyone. Today we will talk about the different imaging modalities for the prostate cancer. I am Dr. Jamal, resident of urology. My moderator is Dr. Tanji. Imaging for prostate cancer. So our learning objectives are TRUST, MRI, multiparametric MRI, PI-RADS, PET scan, and bone scan. Last but not least, TRUST. Transrectal ultrasonography of the prostate provides multiple diagnostic utilities, including assessing prostate volume, locating focal abnormalities, assessing patients with infertility with suspicion of obstruction, and guiding prostate biopsies. So, TRUST is also most widely used clinical imaging method for the prostate is also, and also essential prostate cancer biopsy guidance. How prostate appear on TRUST and how we will do the TRUST, and how to evaluate the prostate as a help of transrectal ultrasonography. First of all, we will take the patient on left lateral position, and this is the TRUST probe. This one we have to envelop the TRUST probe as a enveloper or a condom to protect the chances of the infection, and the help of azilocan gel, and we will insert this probe to the NS. The ideal insertion places to the anorectal junction, not to the complete rectum, because that will be so painful. The when we will do a TRUST, we will ask the patient to empty the full bladder, so that will help the patient for the less painful. And also we will see the post-void residual in the urinary bladder. This is the images of prostate, the heart-shaped image of the prostate. This is there's on the capsule of the prostate, and this one is the peripheral zone, homogeneous. This one, and this is the cystic lesion of the prostate, and this is the calcification of the prostate, enlarged prostate around. This is the real picture of our center in ER1, and this 130 prostate volume is the 130 now. And this one, how to evaluate the volume of the prostate. This is the AP diameter. This one. This is the longitudinal. This is the transverse, and this is the longitudinal. And this is the central zone of the prostate. And this is the urethra. This one is the urinary bladder. So TRUST in prostate cancer, standard TRUST is not reliable at detecting prostate cancer. Prostate cancer appears as hypoechoic area in peripheral zone. Not all cancer appear as a hypoechoic area on a scan, and up to 40% cancer are azoechoic. Hypoechoic area is not a specific finding for malignancy and can be present in benign conditions such as prostatitis. Role of TRUST in prostate cancer. Used for local staging of prostate cancer. Diagnostically, transrectal ultrasound is used to measure the volume of prostate gland, an important factor in computing PSA density. Moreover, the volume as measured with transrectal ultrasound can be used in staging and predictive mammograms. When prostate cancer is suspected, the diagnostic test of choice is a systemic needle biopsy with ultrasound guidance. So, role in detection of the extra prostatic involvement, capsular bulging and irregularity, obliteration of the fat flange, sensitivity of extra prostatic involvement varies from 50 to 90%, and specificity of 37 to 85%. This one, the literature. Role of trust in prostate cancer treatment. Transrectal ultrasound continues to play an important role in therapy as directing brachytherapy seeds into the prostate. And also the cryotherapy of the prostate also requires ultrasound guidance as it has high intensity focus ultrasound, which coupled with ultrasound targeting is used for focal ablation of prostate cancer also. So new treatment approach such as hyperthermia, photodynamic therapy, direct injection of the oncolytic virus, tumor vaccines, and gene therapy also depend on transrectal ultrasound for easy access to cancer of the prostate. The newer modalities, new sonographic modalities provides promising preliminary findings either alone or combined with so-called multiparametric ultrasound. Microdoppler, sonoelastographic contrast enhanced ultrasound, and high resolution micro ultrasound. However, these techniques will still have limited clinical applicability due to lack of standardization, lack of large-scale evaluation of inter-reader variability, and unclear result in transition zone. So the conclusion is TRUST is portable, easy to use, and readily available, and can easily assess prostate volume. Because of its limitations, TRUST may not be an accurate tool for staging prostate cancer. Use of power Doppler can increase rates of detection to some extent. Newer techniques such as contrast and enhanced TRUST have been reported and studied to increase sensitivity for tumor detection.
So we have Dr. Amit Lalwani with us. So is there any role of cancer detection during TRUST? And what is the sensitivity of that TRUST?
TRUST sensitivity in detecting the lesion in the prostate is about 40 to 50%, and which is also depend upon the experienced radiologist, because a very subtle lesion and does not always rely on the hypoechoic lesion, because sometimes prostatitis can also appear as hypoechoic areas in the peripheral zone. But when there's a hypoechoic areas with increased vascularity along with which can raising the suspicious, and nowadays also prostate elastography, which is very helpful, which show that if there's a stiffness is there in this lesion, that is yield the more sensitivity in the sensitivity of suspicion of the prostatic cancer.
So there are so many new technologies are emerging, like a nano-bubble technique with the contrast enhanced imaging of ultrasound. Is there, you have seen any nano-bubble technique and any? But these are experimental. We did not find any video. If you find the video, then we can present in this presentation.
We have only read in the literature and books. Otherwise, we haven't observed as yet. And these are the technique in which the microbubbles has been injected into the IV, and depend in same like CT scan, like IV is contrast has been given, and those prostatic lesion which are more vascular that pick up the contrast, and that can increase the yield of the detecting the prostatic cancer, but they are still is not available in the Pakistan.
Dr. Amit, we read about contrast enhanced TRUST. So it is the same machine which we do TRUST with, and we inject that contrast, or there is some hardware upgradation also required for this technique?
The machine is remain same, only the microbubbles and the contrast has been given, and then rely on the which there's a contrast uptake in the ultrasound, which can be seen on the ultrasound, which can be same ultrasound machine can be used. But for prostate elastography, the update software has been required, and otherwise for the microbubble technique, though no upgradation of a machine has been.
And it's not experimental. It is now not only discussed, but also it has been widely addressed in literature also. So both these techniques, the NANO-BUBBLE and the CUS, now they are discussed on platforms like ASCO, and and since nothing is needed, just another kind of contrast medium which can be injected and can concentrate on the area where you want to have it. It has got many other purposes beyond prostate also. So this is something which is coming up because of many reasons, because of its portability, because of its low cost, because of its availability to many other areas. For instance, you can move it to many different rooms within the same hospital, or maybe within the same city to different hospitals. So with one machine, you can do justice to many patients, to many pathologies. So this is the kind of advantage with this technique. With multi-parametric MRI, you got to have a lot of money in your pocket, and it cannot be moved. Once it is there in the hospital in which it is.
Dr. Amit, can we say that TRUS is only specific to examine the hypoechoic area of the prostate?
For the prostatic CA or other pathologies?
Prostatic CA or prostate other pathology?
Is the Dr. Jamal has been explained in this presentation, prostatic CA not always is the hypoechoic. Sometimes they are also appear as the isoechoic lesions. So it is not necessary that is a hypoechoic lesion in the prostatic CA, but is if because of the more prostatic CA appear as hypoechoic, so that is isoechoic also very difficult to detect on the ultrasound. So it is not necessary that appearing hypoechoic lesion.
May I answer this question a little further? You see, for any probe which is used for ultrasound, you can have a spectral image which gives you the echogenicity. But if you combine it with Doppler, you can have a pretty good idea about the vascularity of that organ. If that concept is applied through TRUS, and I have also used it some way back many years, you can have a very good understanding of the prostate you are dealing with. Either the prostate is having a lot of blood vessels, blood supply. That means that the prostate is in a stage, maybe it's in inflammation, maybe it's prostatitis. You can also have a kind of a ratio between the vessel as well as parenchyma. So there is a formula for it. You can also have it for detection of carcinoma, where the ratio between the vessel and the parenchyma is altered slightly differently. You can also guide your needle, for instance, the 5 o'clock and the 7 o'clock position, where the neurovascular bundle actually enters and exits the prostate by having this mode of transmission turned on. For instance, if your needle is going towards the 5 o'clock position for the biopsy, and you think that you might hit a vessel, then an intelligent ultrasonologist can always have this information by just putting a finger on the Doppler, whether the vessels are there or not. So there are many things that can be explored. It's not only isoechoic or hypoechoic regions that can be seen through TRUS. So it's a tool, it can be used intelligently.
CT scan, it has virtually no role in prostate cancer detection or primary tumor staging. CT does not provide sufficient soft tissue contrast beyond size assessment of the prostate. The major role of CT is in the nodal staging of prostate cancer. As you show enlarged left external iliac nodes. This one is the suggestive of nodal metastasis. So CT has been used to monitor bone metastasis, but bone scanning and MR image are superior to CT in the diagnosis of bone metastasis. Latic and bastic bone metastasis will commonly be visible at CT also. So role of MRI. MRI offers increasingly reliable visualization of potentially significant prostate cancer. The advantages of MRI to better select patients for biopsy, to facilitate direct targeting of lesion during biopsy, information for staging tumor extent, and monitoring treatment response. This is the anatomy of the prostate. The help of MRI. This is the preferred zone of the prostate. This one is the capsule of the prostate. The transition zone. This one is the neurovascular bundles. And bilaterals are, this one is the seminal vesicles. The key advances that have contributed to the increased clinical utility of MRI for the prostate include the use of magnets with high field strength, such as 3T. 3T is a traditional MRI machine operated a strength of 1.5 Tesla. A Tesla is a unit of measurement quantifying the strength of a magnet field. A 3D MRI is generated as a magnet field that is twice as strong as a normal MRI and 10 to 15 times as strong as open MRI scanner.
What kind of MRI do we have?
1.5 Tesla.
The use of endorectal coil and the development of a novel set of imaging sequences that can be used in combination, so-called multi-parametric MRI, to improve both lesion identification and characterization. So now we will talk about the multi-parametric MRI. Multi-parametric MRI can be briefly summarized as a method of trying to obtain an ideal three-dimensional prostate image by combining T2 weighted imaging, diffusion weighted, and dynamic contrast enhanced. So I think the first is the diffusion weighted imaging with an apparent diffusion coefficient, which tell about the cellularity of the tissue. And T2 weighted imaging, which defines anatomy of the prostate, and dynamic intravenous contrast enhanced.
Dr. Amit, can you explain what kind of this imaging is this? Diffusion weighted imaging and dynamic intravenous contrast enhanced imaging.
Now modern, even it is very common to see the prostate cancer on without T2, because T2 is not as much gold standard remain is for the prostatic cancer. Diffusion weighted image is must is required, because diffusion weighted is a basic upon the principle upon the osmosis of water molecules in any lesion. So that is if the water molecule transfer is restricted, that show the restriction. So depend upon that basic rule, any tumor or any abscess which can also restrict the water molecule, which can area is appear as a DW right on ADC appear hypotensive. So that on this basic rule that we apply on the prostatic cancer and easily pick up the lesion, even in small lesion less than 1.5 centimeter lesion, which is easily missed on the normal T2 weighted images. So that is the diffusion weighted technology is easily applicable and very increase the yield of the prostate cancer. And how the concern about the dynamic contrast imaging, which is also imaging technique, which is depend upon the, which is also simple rule, just like RCC, that is the lesion easily the early contrast enhancement and early washout, just like RCC. So that the dynamic contrast imaging, when we inject the contrast, the lesion pick up the contrast compared to prostatic parenchyma, and it is easily early washout, so that we can pick the lesion. That is the lesion. That is a very important technique in the PI-RADS technique, PI-RADS classification.
Okay. Can we have all these three imaging modalities on 1.5 Tesla?
So that is depend upon the software. 1.5 Tesla machine is if the software is updated, especially TWI is easily available on the 1.5 Tesla, but unfortunately it's a software update in our department is not is new. But in the most of machine like KU 1.5 Tesla, they are using the diffusion technique from the 1 decade but is not available in the world, unfortunately. But diffusion method is not technology, not test newer now, because very old technique, and it is just like a brain infarct. That's also diffusion method may deploy upon the diffusion method technique.
So the indication for multiparametric MRI in local staging T2 versus T3 disease, detection of clinically significant prostate cancer, localization, catheterization, recurrent disease, and also for the focal therapy. T2 weighted images for the prostate carcinoma. For the peripheral zone tumor, low T2 signal intensity replacing the normal high T2 signal intensity in the peripheral zone. In the transitional zone tumor, a homogeneous low signal intensity region in the transition zone, poorly defined or speculated lesion margins, lack of a low signal intensity seen commonly and associated with benign adenomatous nodules, and interruption of the surgical pseudocapsule. And also for the urethral or anterior fibromuscular stromal invasion and lenticular shape. So this is the T2 weighted imaging. This is the normal prostate. Peripheral zone is high signal intensity. And multi-nodular hypointense lesion in the transition zone. This one. And also in the prostate cancer, this is the peripheral zone, signal intensity area of low signal intensity in the left peripheral zone of the prostate. Transition zone, the better using of T2 weighted imaging is for the transition zone. So this picture that T2 weighted imaging is the normal for the transition zone, procedures appear normal. In the T2 weighted imaging, this is the hypointense or heterogeneous encapsulated area on the left side of the prostate, in the left transition zone of the prostate. This one is the heterogeneous and encapsulated area. And T2 weighted imaging, and this is the heterogeneous signal intensity with obscure margin of the lesion that do not fall in other categories. Just like this. So the T2 weighted imaging is better for the transition zone. And this one is the lenticular or non-circumscribed homogeneous modalities, and also the hypointense area. The fifth is also the similar to the fourth one. So the T2 weighted imaging is better used for the transition zone. And now the peripheral zone, diffusion weighted imaging or ADC for the peripheral zone. This is the peripheral zone, which is normal. This is the indistinct hypointense area in the peripheral zone. And images third, focal mild to moderate hypointense area in the peripheral zone of the prostate. And this one is the hypointense area. This picture in the diffusion weighted imaging is also the markedly hyperintense. So in the peripheral zone, in the ADC, this area is the hypointense and focal markedly. This one. Fourth is also similar to the five. So T2 weighted extracapsular extension, asymmetry of the neurovascular bundles, tumor encasement of the neurovascular bundle, a bulging prostatic counter, and on irregular speculated margins of the capsule, and obliteration of the retroprostatic angle, and capsule retraction, in a tumor capsule interfere of greater than 1 centimeter and a breach of the capsule with evidence of direct tumor extension. So this is the feature of seminal vesicle invasion. This picture is the axial section of T2 weighted imaging at the level of the prostatic base to demonstrate the low signal intensity replacing the normal signal intensity of the left peripheral zone with direct tumor extension from the base of the prostate into both seminal vesicles. So disruption or loss of the normal architecture of the seminal vesicle, focal low signal intensity within and along the seminal vesicle, enlarged low signal intensity ejaculatory ducts and seminal vesicle, obliteration of the angle between the prostate and seminal vesicle, and demonstration of the direct tumor extension from the base of the prostate into and around the seminal vesicle. So this one, the T2 weighted imaging drawbacks or some prostate tumor are also intense. And this is the picture of the T1 weighted imaging. There is a high signal intensity on T1 weighted imaging in the right peripheral zone of the prostate, with little signal reduction on the T2 weighted imaging. In the little signal reduction and no restricted diffusion on diffusion weighted imaging. So limited specificity because of there are other possible cases of low T2 signal, including hemorrhage, prostatitis, scarring, atrophy, and effect of radiation therapy, cryosurgery, or hormonal therapy. So post-biopsy hemorrhage may hamper tumor detection. So the image appearing depend on the length of time between the biopsy and MR imaging, at least a delay of 6 to 8 weeks arising in the 6 weeks is recommended, and prostate cancer arising in the transition zone poses additional. Now we come to the diffusion weighted images. So reduced diffusion of water in prostate cancer has been attributed to the increased cellularity of malignant lesions, with reduction of the extracellular space and restriction of the motion of a larger portion of water molecule into the intracellular space. Therefore, diffusion weighted imaging provide an important quantitative biophysical parameter that can be used to differentiate benign from malignant prostate tissue. Dynamic contrast enhancement MR imaging is on advanced prostate imaging modalities that allows derivation of parameters that are closely related to microvascular properties and angiogenesis in tissues. In prostate cancer, increased tumor vascularity leads to early hyperenhancement, higher and earlier peak enhancement than in normal tissue, and to rapid washout of contrast material from the tumor in comparison with normal prostate tissue. So microvascular alterations and neurovascularity are in general most severe in prostate cancer in comparison with other processes in the prostate such as BPH or prostatic endoepithelial neoplasia. Now we will talk about the PI-RADS. PI-RADS is a system used to catheterize and assess all focal intraglandular prostate nodules seen on MRI. The system includes technical standards for scanning hardware and protocols for imaging acquisition and interpretations. It also provides standardized terminology for reporting and a sector map for all location with the gland. The PI-RADS assessment categories are based on the findings of multiparametric MRI, which is combination of T2 weighted imaging, diffusion weighted imaging, and dynamic contrast enhanced imaging. The PI-RADS system categorizes prostate lesions based on the likelihood of cancer according to a 5-point scale defined as the following. The PI-RAD 1 has the very low clinically significant cancer, highly unlikely. PI-RAD 2 has the low clinically significant cancer, unlikely. The PI-RAD 3 intermediate clinically significant of cancers is equivocal, and PI-RADS 4 is PI-RADS 4 high clinically significant cancer is likely, and PI-RAD 5 score is very high, so the clinically significant cancer is high likely. PI-RADS assessment categories. Assessment of a PI-RADS assessment categories for each lesion is based on the scoring of T2 weighted imaging, diffusion weighted imaging, and dynamic contrast enhancement sequences according to the zonal anatomy. So the peripheral zone is situated on the posterior and lateral side of the prostate, surrounding the transition zone. For the peripheral zone, the diffusion weighted imaging is the primary determining sequences dominant technique to assign the PI-RADS assessment categories. So this is the peripheral zone. So in the peripheral zone, diffusion weighted imaging in the PI-RAD 1 score is will be normal. In the PI-RADS 2 score, the diffusion weighted imaging will be indistinct hypointense area will be seen in the peripheral zone in the diffusion weighted imaging. And PI-RADS 3 scoring and the diffusion weighted imaging, the peripheral zone will be seen mild to moderate hypointense area on the peripheral zone. And PI-RADS 4, in the peripheral zone, the diffusion weighted imaging will be seen focal markedly hypointense area. And PI-RADS 5, in the diffusion weighted imaging, the peripheral zone will be seen similar to 4, but more than 1.5 centimeter are the definitely extra prostatic extension. In the transition zone, the better image to use for the transition zone is already we talk about it, is the T2 weighted imaging. In the T2 weighted imaging, the transition zone will be appear in the PI-RAD 1 score will be appear normal. In the PI-RAD 2 scoring, the transition zone will be appear circumscribed, hypointense or heterogeneous encapsulated nodules in the transition zone on the T2 weighted imaging. And the PI-RAD 3 scoring, and for the transition zone, the PI-RAD 3 score will be seen heterogeneous signal intensity with obscured margin or lesion that do not fall in other categories. In the PI-RAD 4, the transition zone and the T2 weighted imaging will be appear lenticular or non-circumscribed, homogeneous, moderately hypointense. In the PI-RAD 5, the transition zone will be seen on the T2 weighted imaging similar to 4, but more than 1.5 centimeter or definitive extra prostatic extension.
Dr. Amit, PI-RAD scoring does not include the central zone. So how will we score the PI-RAD scoring of central zone? If there is a chance of 5% tumor in the central zone of in CAP. So how will we categorize the PI-RAD scoring in central zone tumor?
The recommendation is rely on the T2 images because the diffusion weighted sequences in the transitional or central zone is not as much yield as compared to the peripheral zone. As also has been pointed out earlier, that is because of a no diffusion restriction, multiple nodule is already because of BPH is there, so they're difficult to see on the diffusion weighted imaging and diffusion restriction. So that more rely on the T2 imaging because the T2 images is show the high point there, but it's not as gold standard as that of a peripheral zone. So that is the not as much sensitive. T2 is even in T2 imaging in the central zone for the detecting the tumors, but only tool is a T2 and dynamic contrast imaging, so that we can be helpful. But if any suspicious is still high, though, but sometimes new technique like MRS can be helpful, which is very important technique in which we can see the metabolite like choline to citrate ratio, which can increase the ratio, that is yield the more. The ratio is about, if the ratio is 0.5, the non-significant. If ratio is more than 2, that is quite suspicious, is yielding to high ratio, so that is yielding the tumor suspicious is high. So that in that case, we can raise the possibility of tumor. So the newer modality has been helpful, but T2 imaging, unfortunately, not it as much in yielding the tumor in the central zone.
Second question is, can we calculate PI-RADS with the current infrastructure that we have with us?
And basically, we already said that is a diffusion sequence is very important in this. Most of tumor in the peripheral zone. Unfortunately, the diffusion rate is available in the department, but not as high frequency or high yield because of they're not giving the high resolution images. Sometimes once in the I see the diffusion rate sequences which give the good result, but is a 100 patient, only one patient has been good result has been obtained. So that is due to the not as much software available, so that we are not in detail reporting of PI-RADS, because it's important to have a diffusion sequence, and also dynamic contrast sometimes is important because of which is also can increase the yield. So that is on this machine is when you're unable to report as a PI-RADS, which can be reported, but is not possible.
So is it the software or is it the endorectal coil?
Endorectal coil is give the more result, but software is very important, and machine strength is that if the machine strength is increased like a 3 Tesla, even we haven't endorectal coil, which can increase the yield. Because endorectal coil only used which is those patients who are highly suspicious, that can even which not yield on the current MRI on 3 Tesla, then in which case the high endorectal coil has been used, because endorectal coil is also most of patient is uncompliable endorectal coil, because of we putting endorectal coil for half hour and patient is not as much comply on the endorectal coil, but endorectal coil is increase the yield, no doubt, because of is close to the surface of prostate, so that it gives the good high resolution images. But endorectal coil is not as much required each and every patient. Only required when the result became equivocal on the current MRI. In these patients, we can use endorectal coil.
So the PET scan, PET uses compound label with positron emitting radioisotopes to detect pathologic processes. Most clinical PET studies to date have been performed with the glucose analog fluorine, 18, and fluorodeoxyglucose or FDG. Cancers have increased metabolism and utilize the less efficient glycolytic pathway, both of which lead to increased glucose analog uptake. Increased glucose uptake and metabolism in tumor are facilitated by an elevated expression of glucose transporters, which has been shown in several cancers. The magnitude of the elevated FDG uptake and accumulation in tumors is commonly expressed by the standardized uptake value defined as the ratio of activity per unit mass in the lesion. The teaching points for the PET scan is FDG is limited because of the relatively low glucose metabolism of most prostate tumors, but FDG may have a role in response assessment of osseous disease in metastatic castration-resistant prostatic cancer and as a prognostic indicator. So 11 carbon choline and 18 fluorine choline are sensitive and specific for disease detection in high-risk staging in biochemical relapse after radical therapy in patients with high PSA level and high PSA velocities. So 68 gallium PSA is highly sensitive for biochemical relapse after radical therapy in patient with lower PSA level compared with 11 carbon choline and 18 fluorine choline. Significance of PET scan in prostate cancer. PET imaging become relevant because of the limitation of conventional structure imaging and the staging of extra prostatic disease and the restaging of prostate cancer patients after biochemical relapse and in response assessment. So the various PET tracer have been investigated for their use in prostate cancer, and thus far 5 have been approved by the FDA. FDG benefit for the prostate cancer is very limited for the response assessment of the osseous disease and metastatic castration-resistant prostate cancer, and carbon choline or fluorine choline in the large studies. The role in prostate cancer is the high-risk staging, biochemical relapse, and the high PSA levels. And gallium PSMA ligands in the large studies, there's also role in prostate cancer imaging is the biochemical relapse at low PSA level. If sodium fluoride, the osteoblastic activity in bone, the benefit for the prostate cancer is just for the bone metastatic only. And if fluocyclovine is the initial result, role in the prostate cancer is undergoing elevation but appears superior to choline in the setting of biochemical relapse. So the radionuclide bone scanning, it has no role in prostate cancer detection or local stage. However, bone scanning continues to be the mainstay of diagnosis of initial spread of cancer to the bone for the bone mets. A focal area of increased tracer uptake, usually in the axial skeleton related to host osteoblastic bone response to tumor invasion. However, other causes of altered marrow signal intensity, for instance, infection, infarction, trauma, and can mimic metastatic disease at MRI. This is the picture of the bone skin. There's the skeletal scintigraphy, and this bone scan show in the increased tracer concentration involving most of the axial and appendicular skeleton. So this is the bony mets which show on the bone skin. Radionuclide bone scanning. Radionuclide bone scanning can also be used to assess the response to treatment, as uptake usually decreases after chemotherapy, hormonal therapy, or radiation therapy if a response is obtained. And patients with prostate and breast cancer a flare phenomenon may be observed where uptake initially increases after chemotherapy or hormonal therapy, peaking at 6 weeks after treatment as bone turnover increases as part of the healing process. Care must be taken in this situation to avoid mistaking apparent new lesion for area of new metastatic disease when subtle changes were in fact present in prior studies. So I already talked about this. The newer technology, the use of a microbubble ultrasound contrast agent for transrectal color Doppler targeted biopsy significantly improve the detection of the prostate cancer compared with systematic biopsy following conventional grayscale ultrasonography. In the first picture, the conventional grayscale ultrasonogram show homogeneous echo texture with no definite focal lesion. In the picture B, the contrast agent enhanced color Doppler ultrasonogram show one small hypervascular area on the right side of the prostate.
Last slide.
The last NANO-BUBBLE ultrasound has already, we talk about that. Ultrasound imaging is routinely used to guide prostate biopsies Yet, delineation of tumor within the prostate gland is extremely challenging even with microbubble contrast. Latest studies are focusing on evaluating the application of a novel nanobubble ultrasound contrast agent targeted to the prostate-specific membrane antigen and ultrasound imaging of prostate cancer and experiment or bearing proton animal models. Thank you.
Very much.